Okay, I think we've got a critical mass. So thank you, everybody. Good afternoon. My name is Lisa Hunter. I'm the Senior Director for Federal Policy and Advocacy here at United States of Care. I'm so excited to welcome you on behalf of United States of Care and Primary Care Collaborative for this webinar titled Better Primary Care from the People's Perspective, supported by the Commonwealth Fund. Next slide, please. Great. Okay, some wayfinding. And before we get started, I wanted to go through some housekeeping. For folks joining in, you can ask our speakers and panelists questions using the Q&A feature on Zoom. We do have auto-generated closed captioning available throughout the webinar. And this webinar is being recorded, and you will be sent a link to the recording as well as the slide deck we used today in an email that follows the webinar. Next slide. Great. We're joined today by Natalie Davis, CEO and co-founder of United States of Care, and Ann Greiner, CEO of the Primary Care Collaborative, PCC, who's going to contextualize the broader primary care landscape for us. After this, we're going to have Dr. Vettis Haynes, the Senior Director of Research and Community Engagement here at United States of Care, walk through United States of Care's new research findings on primary care. Anne is then going to moderate a panel discussion with Dr. Haynes and Dr. Thomas Warkup of the Rhode Island Primary Care Physicians Corporation. And then we're going to follow that with audience Q&A. So to get this started, I wanted to pass it on to Corinne Lewis, Assistant Vice President of Delivery System Reform at the Commonwealth Fund, to briefly discuss why they decided to support this work. So let's go ahead and bring her up on the screen.
Great. Hi, everyone. Thank you all for being here, and thank you to United States of Care and the Primary Care Collaborative for all their work on today's webinar. I'm Corinne Lewis, Assistant Vice President of Delivery System Reform here at the Commonwealth Fund. For those of you not familiar with us, we are a national nonpartisan foundation dedicated to affordable quality healthcare for everyone. And our delivery system reform program has a focus on strengthening primary health care, particularly for underserved populations. We are focused on primary care because evidence shows that it's the foundation of an effective healthcare system. It's one of the only health services associated with improved life expectancy and will be essential to addressing our most pressing health crises, including declining life expectancy, increased rates of chronic illness, and the growing behavioral health crisis. But as we all know, the future of primary care is at risk, with access to high quality care becoming even harder to come by. In order to design a better primary care system that works for everyone, particularly those that are underserved, we felt it was really important to take a step back and ask patients for their perspectives. We've had the privilege of partnering with United States of Care over the last several months to do just that, ask patients what they value when it comes to primary care and what they want to see change. And we hope the results you hear today will shed light on what really matters to people and how policymakers, practices, and we as a community can really do better. I'm looking forward to the discussion.
Excellent. Thank you, Corinne, and thank you to the Commonwealth Fund for their support and leadership in this space. I'm going to go ahead and turn it over to Natalie Davis, CEO of United States of Care. Natalie, go ahead.
Great. Thank you, Lisa. And it's so great to see so many people logging in and chiming in to be a part of this really fascinating conversation and for the rolling out of this research. As Lisa mentioned, my name is Natalie Davis. I'm the CEO and co-founder of United States of Care. For those of you who are unfamiliar with United States of Care, we are a nonpartisan nonprofit working to ensure that everyone has access to quality, affordable health care, regardless of their health status, social need, or income. We bring the voice of people to the halls of power to advocate for durable policy change at the state and federal level to make sure that we actually make a difference in people's healthcare experiences. And as you'll see today, our work is grounded in research and community engagement, listening to people's needs, and really understanding their desires across demographics for a healthcare system that works for them. And we hear from people across the country, across demographics, across party affiliation, that they want a healthcare system that's affordable, dependable, personalized, and understandable. And of course, primary care is such an important part of that. But we found the patient voice has been largely absent from conversations around primary care, which we know is a gateway to the healthcare system for so many people. And with the turning political tides, the clinical shortage, people struggling to access healthcare they need, it's more important than ever to really understand how patients' experiences in primary care can help us find the way that we can change it to make it better for people. So as we said, with the gracious support from Commonwealth Fund, we sought to do exactly this with a multi-month mixed methods approach to research, where we're going to present the findings today, which I hope you'll find very fascinating. And we're incredibly excited and grateful to partner with the Primary Care Collaborative on this webinar, who will help us understand our findings and fit it into a broader context on primary care. So with that, I'd love to pass it to Ann Greiner, the CEO of the Primary Care Collaborative. Over to you, Ann.
Well, thanks so much, Natalie, for that wonderful introduction. I'm Ann Greiner, President and CEO of the Primary Care Collaborative. And we are thrilled to partner with US of Care to bring the patient perspective to policymakers. Absolutely critical. Could not agree with you more that we don't have enough knowledge of patient needs, values, and preferences to inform policymakers about how we should reform and improve this foundation of our healthcare system. For those who may not know the PCC, Primary Care Collaborative, we are a national, nonpartisan, multi-stakeholder organization that advocates for better health and well-being for all Americans by strengthening primary care. And we convene stakeholders across the healthcare system and landscape to improve the nation's health by advancing high-quality, whole-person primary care. As Corinne mentioned, the evidence is unrefutable that primary care is the cornerstone of all effective healthcare systems across the globe. But in our country, we have years of underinvestment in primary care, and really what I would describe as broken payment models that have placed a lot of burdens on primary care. And all of us are experiencing the downstream effects of this. We're not able to get the kind of primary care we would like, oftentimes. And we see those that are providing the care stressed out, not able to give us the time and attention that we are seeking. So as our nation grapples with rising costs and rising chronic conditions and lower life expectancy, and we bring stakeholders together to advocate for really strengthening this foundation that we know can improve healthcare outcomes, can reduce chronic conditions, and really over time, really bring costs in check. That's why we're thrilled to be here with the US of Care for the release of this really important research. We hope it provides important context to policymakers, whether they're on Capitol Hill or in state houses across the nation. And really very much look forward to the findings and the conversations that follow. Thank you.
Thanks so much, Ann. And couldn't agree with you more. Really excited to get this research out into the wild. So I think I'm going to toss things over to Dr. Haynes to take it from here. She's going to take us through the research findings I know you all are eager to hear about. So take it away, Venice.
Thank you, Lisa. Thanks to everybody, and thank you to Commonwealth again for the opportunity to do this work. We are really excited to present some of the findings of what we've heard people say about primary care recently. So first, though, let's take a look at the current primary care landscape, as there are several challenges facing primary care today, as Ann and others mentioned. And so essentially, we're seeing a significant decrease in the availability of primary care clinicians, particularly in rural areas, to keep up with the demand, making it harder for people to find timely care. Additionally, physician burnout is high, which leads to concerns about workforce retention and the quality of care received as a result. And consolidation in healthcare really means that the standalone primary care practices are becoming less common, potentially limiting patient choice and access. But on the other hand, we're seeing an increase in virtual care options and urgent care facilities, which can help meet the high demand for care, but may not provide the same level of comprehensive continuous care as a traditional primary practice could. So if you go to the next slide, I want to talk really quickly before we dive into the findings about our methodology. As Natalie mentioned, we took a mixed method research approach First with a national poll conducted with Morning Consult, where we had surveyed over 3,300 adults, which included oversamples of 550 rural and people of color populations to ensure that we had a diverse representation, and wanted to drill in deeper into some of the communities, the marginalized communities that have been harmed most with accessing primary care. In addition, we conducted 2 focus groups with people across the country with rural adults and one with young adults aged 18 to 30 to gain deeper insights into their experiences with primary care at various rates of interactions with the healthcare system. So let's go to some of our key takeaways from our research. There are 4 of them, so if you have to log off after this, here are some of the main takeaways you can take with you before you come back and watch later. First, we found that people essentially were generally satisfied with their primary care and actually highly prioritized having a regular primary care clinician. However, young adults, people in rural communities, and people of color face significant barriers to accessing primary care, mainly due to cost and access issues. We found that the satisfaction with primary care actually increases with age, likely due to more established relationships with clinicians and better insurance coverage. And finally, while insurance coverage is a major factor in choosing a primary care clinician, the ability of a clinician to listen, communicate effectively, and be culturally responsive is top of mind and most important, especially for adults of color. So if we go to the next slide, let's talk a little bit about what people consider to be primary care, because we did not want to assume, we went into this research not wanting to assume that when we talk to people, everyone had the same definition of primary care. So essentially people told us that it encompasses a wide range of services to include routine physical exams, screening exams like cholesterol, diabetes, depression screenings, prescription refills, a place where they can go to get general health concerns addressed, vaccines and immunizations, and chronic disease management. And as one of our focus group participants said, it's essentially the first line of defense for health and wellness that provides comprehensive and continuous care for not only themselves, but for their families. So one of my favorite slides I like to talk about, if you go to the next slide, you will see are the primary care sentiments. From our focus groups, we often like to open our conversations with, what's the first word that comes to mind when you hear the term healthcare? We expanded on that a little bit. And so participants expressed essentially negative sentiments toward various aspects of the healthcare system. But interestingly, their feelings about primary care remain relatively neutral. So I'll leave this here for you all to absorb a little bit. But we think that this might suggest that people genuinely value primary care, but may have negative experiences with other parts of the healthcare system, such as insurance, hospitals, and the overall cost and complexity of it that gives more of the negative connotation. So let's get further into it. Starting with access, our research found that 74% of adults have received primary care and services within the last 2 years. And that includes either in person or virtually. And we happen to observe a very clear trend that as age increases, so does the utilization of primary care services. We think this could be attributed to several factors, including increased health needs with age, better insurance coverage among older adults, and more established relationships with primary care providers. Next slide. But unfortunately, we saw a lower utilization of primary care services among adults of color and those without health insurance, which definitely need to be addressed to ensure the availability, both the availability and the quality of care that every population deserves. Next slide. So when we asked about some of the reasons for seeking primary care, adults primarily cited routine checkups, prescription refills, and preventative care being the top 4 reasons. And this suggests that people, as we said before, view primary care as essential not only for maintaining ongoing health conditions, but as we've heard from other research, they are really prioritizing the preventative aspect of their care. Next slide. So, while we have found that most adults find it easy, chuckle, to access primary care services, there are some exceptions. For example, we saw a significant drop in the ease of access across different generations. In particular, the Gen Zers, uninsured adults, and those as identifying as Asian American, American Indian, Alaska Native, or Pacific Islander. And those reasons for the difficulty accessing care include health insurance issues, scheduling and wait times, financial constraints, and provider availability. Next slide. And so for rural communities, we heard in our focus groups that hospital closures, transportation, and affordability are some of the main concerns when it comes to accessing healthcare, including primary care in these instances. These challenges really highlight the need for targeted interventions in rural communities to improve access to care, because access to care in that regard has a little bit of different context and needs than in other urban and suburban areas. Next slide. So as an example, this quote from a rural focus group participant illustrates the challenges that we've actually heard faced by a number of people in rural communities and other areas of our research. The closure of hospitals, limited transportation, and limited transportation options, coupled with long distances to travel for care, create significant barriers to accessing timely and necessary healthcare services when needed. Next slide. So let's talk a bit about affordability. We heard a lot in our research that affordability is a major barrier to accessing primary care for many adults. And what we saw, interestingly, was almost a quarter, just over a quarter of adults reported not receiving primary care in the last 2 years because they couldn't afford it. 22% of them said it was due to having lack of health insurance. And so this tells us that even with insurance, people still struggle to afford primary care services, which highlights the need for policy solutions to really dig into and address the cost of care. Next slide. So looking a little bit deeper, we found that rural populations were more likely to report not seeking primary care due to cost compared to urban and suburban populations, which further emphasizes the unique challenges made by rural communities in accessing affordable care. Next slide. As I read this quote, from a rural focus group participant, which underscores the importance of the need for affordable healthcare in these communities. Essentially, access to affordable care is essential. It's not optional for receiving or achieving better health outcomes, really for all populations. Next slide. So, thinking about the experiences people are having with primary care, we often like to get and gather sentiments when we're talking to people. And so here we talk about how finding a primary care clinician can be emotionally taxing experience for many adults. And we learned from our focus groups that words like hard or nerve-wracking or stressful, uncertainty, confusion, these were things that were used frequently to describe the process for finding a new primary care clinician or office. Which also highlights the need for a more streamlined approach for how we connect people with primary care providers, clinicians, and services. Next slide. Interestingly, when we asked adults about how much they prioritize having a regular primary care physician, we see that a majority of adults across generations prioritize it a great deal. However, Gen Zers were less inclined to consider having a regular primary care clinician a priority compared to older generations, namely baby boomers. And we think this could be due to the perception of necessity It could be to the limited experience with healthcare as a young person, and or, as we heard before, challenges with both access and or affordability. So we also saw, when it came to choosing a primary care provider, adults prioritize clear communication, addressing the root cause of their problems when they do seek care, and having timely follow-up. Among adults of color in particular, and those in urban communities, we heard that cultural and linguistic understanding of their primary care clinician is a very crucial factor for their experience, and something that they greatly value. Next slide. So this quote from a real focus group participant highlights the importance of a strong rapport and continuity of care with the primary care clinician. Building trust and establishing a long-term relationship with a provider can lead to better communication, improved health outcomes, and greater patient satisfaction. So next slide, despite the challenges, the majority of adults were actually satisfied with their primary care services. This positive finding underscores the value that people really do place primary care and the importance of strengthening the foundation of the primary care system very high. But similar to the utilization trends, satisfaction with primary care increases with age. Again, we could attribute this to better health insurance among older adults, the established relationship, the trust that they've built. But there are still reasons for dissatisfaction, the top being providers rushing through appointments, not spending enough time with them once they get back, and long wait times, both for the appointment and while they're in the doctor's office. Next slide. So when we talk about satisfaction with health insurance coverage, for primary care, the satisfaction with health insurance coverage also varies. High out-of-pocket costs, unexpected medical bills, and difficulty finding in-network providers were some of the main reasons for dissatisfaction with their healthcare coverage, emphasizing the need for improved efforts for affordability and accessibility of coverage. If you remember a few slides back, about a quarter of participants said that they were not able to access primary care because of lack of insurance coverage. So as I begin to close, if we go to the next slide, talking about some of the barriers and solutions, our focus groups revealed essentially that rural and young people have a very clear vision for primary care, that it should be accessible, affordable, and convenient. However, based on the experiences that they've shared, these experiences fall short of the ideal situations that they desire. Rural participants face challenges such as long distance traveling for care, limited transportation, long wait times. And so we need to think about some of these things when we're talking about equitable access to primary care for rural communities in particular. Young people express concerns about high medical costs despite having insurance and feeling like their concerns were not being taken seriously. These types of experiences can erode trust in the healthcare system and essentially discourage young people from wanting to seek care when necessary in the future. And finally, participants associate accessibility with various factors, including appointment scheduling, shorter wait times, effective communication, affordability, and the like. And so we should consider some of these factors when looking to make improvements to the primary care landscape. Next slide. As I wrap, we heard from focus group participants that they want to see lawmakers prioritize reducing healthcare costs first and simultaneously increasing access to services. As we heard, affordability was a key concern for both rural and young participants, which highlights the need for policy solutions to address this issue, as is top of mind, not only for young and rural adults, but I think for adults across the board. Young participants express distrust in the healthcare system, believing that it values profit over people, which underscores that the need to build trust and transparency in healthcare to ensure that people feel confident in seeking the care that they need. And finally, convenience is a crucial element of access for rural participants, while young participants have a broader range of solutions that they wanted to see, including lowering costs for all of their care. So as I close, thank you, and I will turn it over to our partners at PCC.
Well, thank you so much, Venice. So much there, and even more in the report that the US of Care put out. I know from the PCC perspective, we're going to be digging into many of these findings to understand these perceptions, and also to look at responses across different demographic groups, which have really different experiences in the healthcare system. Folks of color, people who are living in rural areas, younger people. So those differences that you've lifted up are really critical. Next slide. Why is this research so important now? Well, for those of us in the primary care space, there has been seismic changes over the last few decades. And for people who are joining us today, if you think about the last 10 or 20 years, you yourself may have experienced change in where you're getting your health care. Perhaps you used to get your health care from a standalone independent primary care practice, maybe with a physician and a nurse, perhaps not, a manager that was the wife of the practicing physician. Things have really changed. People are getting their care in a lot of different places, including practices that are associated with hospitals, retail clinics, and the like. So that's really changed. Who's delivering primary care has really changed too. It is now absolutely a team-based sport. And you may meet with different folks on the team. You may continue to get your care from a physician, but perhaps an NP or a PA or someone else on the team. And obviously, like all facets of our lives, primary care is using a lot more technology. And now you may not even be going into an office to get your care. So understanding how different people are perceiving these changes, their preferences and values is critical. Some things people are celebrating and happy about, others perhaps not so much. And it's important as we think about informing policy to really have an in-depth understanding of what patients are thinking. Next slide. One other really important context, and I think this was alluded to earlier, is that primary care is eroding. So the foundation, in the words of Rebecca Etz, of primary care is crumbling. It's just not as strong as it used to be, and this is problematic. And some of our markers of this erosion are more and more adults and children lack a usual place to go when they have a health issue. So almost a third of adults do not have a medical home or a place where they are known, where their medical records are, where people understand their family context, the community in which they reside, understand their health history. We're also seeing a decline in the percentage of physicians, nurse practitioners, and PAs who are working in primary care. In fact, when you account for those who are becoming hospitalists, which are primary care internists working in hospitals, the latest data shows that only about 19% of those choosing their residency programs are going to eventually become primary care. This is focused on physicians. Next slide. We do see that policymakers are, even though this foundation is eroding, policymakers, employers are looking to primary care to address a growing set of concerns. So as we see this erosion, there are more requests being made of primary care. there's more chronic conditions that people are facing. They're living longer with these chronic conditions. People are looking to primary care to help manage them. We know that there's a rising mental health set of conditions in this country for all ages, including tragically for youth and adolescents, and also substance abuse challenges. Again, policymakers, employers are looking to primary care to help solve these issues and help patients solve these issues, I should say. We also know that much of what affects our health is not something that can be addressed within the medical walls, if you will, and that these social determinants of health or social drivers of health, food insecurity, housing, your ability to pay for your drugs are contributing to your health outcomes. And so people are looking to primary care to screen for those vulnerabilities, but also to help refer patients to community-based services that can address those issues, so that people can get on the pathway to health. Because if you don't have a home and you don't have enough to eat, it's going to be hard to take care of your diabetes, for example. Primary care is also being looked to address other issues, oral health, end of life. The list goes on. And yet the financial foundation to address this growing list is really not there. Next slide. And there's really perception does not comport with reality. A brand new study that just came out in the Annals of Family Medicine shows that actually the public believes that a lot of spending goes to primary care to really address the multiplicity of issues that patients have. And that, that's where most patients are seen in primary care. Next slide for the reality. While it is true that roughly half of all healthcare visits occur in primary care, and thank you for putting the citation in the chat. Thanks so much, Orla. Less than 5%, and let me say that again, less than 5% of all the spending in the US healthcare system goes to primary care. So we're asking primary care to take on more, and they are well positioned to do that, mind you, but we're not financing this critical foundation of our healthcare system. And so this really causes so many downstream problems that patients experience as a result of this underinvestment. Next slide. Thankfully, employers, public policymakers on Capitol Hill and in state houses across the country are beginning to realize that without this foundation of primary care, we will not be able to dig our way out of the chronic conditions that we're facing and increase our life expectancy to be on par with other developed countries. We're right now, in terms of life expectancy, about 5 years behind the Europeans. Primary care is not the only reason, or our lack of primary care is not the only reason for that lower life expectancy, but it is absolutely a contributor. So thankfully, I've got some good news to wrap up here. Policymakers are beginning to act. The Biden administration, and we are also hopeful that this will continue. There's a lot of signals that it will, have advanced new primary care payment and delivery models through the Centers for Medicare and Medicaid Innovation, including a hybrid payment in Medicare's Accountable Care Organizations, MSSP, called the Primary Care Flex model. And also we saw a bundling of codes in the physician fee schedule to pay a prospective monthly payment in advance of the services being rendered, called an APCM code. So why does any of this matter? Again, you heard me say earlier, we need to invest more in this foundation, and we also need to pay differently. Providing primary care with a monthly subscription, if you will, payment in advance allows for more flexibility in how they deliver care and gives primary care practices confidence that they can build out a team because they know that they're going to be getting this regular payment. All of this is critical to provide this more comprehensive set of services that really can address the needs that patients have. On Capitol Hill, we've got bipartisan legislation that was introduced in the 118th Congress, and we're very much hoping and hearing that it will be reintroduced in this Congress from Senators Cassidy and Whitehouse that promotes this idea of reformed payment for primary care and investing more in primary care. And Congress is also looking at, has done some work in the 118th conference, issued a white paper, and we are hopeful we'll take this issue up again to reform Medicare payment. And we're advocating for centering primary care in that reform. Again, all of this matters because how we pay and how much we pay primary care has a huge effect on the kind of care you can get when you walk in the front door of our healthcare system. So I appreciate the opportunity to provide some of the context. And now we're going to have a wonderful panel and dig in a bit more on the data. Okay, so let's just start with Dr. Warkup, who is Chief Medical Officer at the Rhode Island Physician Corporation that is involved in a lot of different kinds of value-based arrangements in Rhode Island. I'm curious, what surprised you most about this research? What would you want to make sure policymakers understood?
Thank you, and great job. The data is wonderful, and I think as a practicing rural health provider, PCP provider, a lot of this resonates with me. I think what strikes me the most about this is as we move from fee-for-service payments to value-based payments, this has been a promise that's been happening for 15 years. I think it's the speed in which it happens is very glacial. We have the expertise at the PCP level, and I think many of the audience members would understand that those prospective payments is how you build out a nutritionist and a behavioral therapist and a case manager and a referral specialist. But despite all the promises, 15 years later, it's still very slow in how Medicare or CMMI does it, how private insurances like Blue Cross and United, Aetna, et cetera, do it. So there's so much instability in the payment structure to where if Senator Whitehouse and Cassidy can make these legislative actions happen, then I think you can find a more stable primary care base that then you can build around. It's just that it's always been a promise of tomorrow. And as a result, it's hard to make commitments today.
Well, Tom, thanks so much for that perspective from the sharp end of care. Venice, you lead research for US of Care, and you regularly think about what resonates with policymakers. So I'm curious, there's so much here, but if you had to select a couple of critical data points, what do you think is most important for policymakers to learn about to inform their thinking?
Yeah, well, I'll start with the positive, and I will say it was surprising to me to see how many people had utilized primary care services over the last 2 years and were satisfied with it, even though the satisfaction could be relative given what you can hear, underneath the hood once you get down to it. What we hear a lot of times from our research is that people really get frustrated with how to navigate and find what they need. And then when you start to get into some of the marginalized communities, particularly in rural communities, as we outlined it in our data, that compounds the problem with them being able to find what they're trying to access. And so if there are ways that we can figure out how to streamline the process for connecting people to care such that they don't have to go outside of, or, establishing a relationship with a provider, or going to urgent care all of the time, or trying to find other options to circumvent the care that they need, that would be that would definitely be one thing. And I think we touched on this, but we've also heard in different parts of our research the importance of having providers that can meet people where they are in terms of various cultural and linguistic needs that they may have. It's not something that's reflected in polling a whole lot, but people sometimes shy away from feeling like they feel empowered to go try to find a physician that can understand them or take the time to understand them and not rush them through their appointment so that they can get their needs met, and can sometimes be discouraged by that. So those are a couple of things that are top of mind for me that we have been hearing from people.
Tom, did you want to reflect on anything that Venice lifted up?
Venice is so on target. I think if you look at telehealth as being a real level setter for underserved populations, within rural environments like Eastern North Carolina or any rural environment, you can project out an academic medical center to where they are. The other thought that's not really been borne out in the data or in many other studies is many people have a smartphone. So some people feel that limitations in technology, it is a limitation that has to be addressed, but it's not a single big barrier that has been thought of in the past. But I think payment parity is the key. These things have to be legislated, because when you give the insurance companies the directive to do it, which many of them have done, they then choose how to pay for it. And they do it at such a marginal rate that it makes it unattractive for healthcare entities to build an infrastructure on telehealth. And then I think you could find people of very diverse backgrounds to talk to other individuals of diverse backgrounds. And the other part next to telehealth would be a United States medical license, where, if I go from state to state, it's a barrier to entry from a business standpoint, that if you found an exceptionally good care provider that is Laotian in Michigan, they should be able to speak to anybody that needs that person, even in Rhode Island or anywhere else that they could be seen. But it's so geographically limited that it just adds more barriers to finding those particular providers in those locations. And certainly if there's not a huge critical mass of of an ethnicity or a culture that maybe has produced the provider in that regard. So I would say telehealth is a key balancer, silver bullet for rural health, but payment parity has to follow it. Otherwise it's discouraged. And hopefully that's something that the Primary Care Collaborative can help with on Capitol Hill.
Well, I do think it's absolutely right that you can have these wonderful ideas about new delivery models, but if the payment doesn't follow it, then the adoption is going to be limited, because frankly, primary care practices are already doing quite a lot that they actually don't get compensated for. So there's a lot of phone calls to help with care coordination and care integration and follow up on things that perhaps the insurance company says, no, we're not going to cover. That actually, even though some of these things, there may be codes to bill for, the juice is not worth the squeeze. There's so much administrative work to doing that. So, I think a bigger theme is, primary care is already doing a lot that's sort of unpaid, after hours and on the weekends, and it's hard to add more to their plates. And at less than 5 cents on the dollar, you can understand how they are under-resourced for what they're being asked to do. So as one of our colleagues, Asaf Batan, says, it's not a charity case. This is absolutely, critical care that people need. And we're just not resourcing it properly.
I'll give an example of today, and you're so accurate. Right now, and one of the payers in Rhode Island where I'm at it's only a 6% primary care spend. And the hope is that they'll spend under the Office of Health Insurance Commissioner has put out recently the regs from last week, that it'll go up to 10% over 4 years. So that's 1% a year over 4 years. So I think the slide of perception of 50 to 60% of the dollars are flowing. Ultimately, the insurance companies will do the least they can to meet the metrics. And that is potentially up to 10% over 4 years. That's not an aggressive timeline.
Well, one could interpret some of the conversation that's going on in Washington, D.C. these days as incremental change is too slow. We need to move quickly. We need bold solutions. And clearly some of the health officials that are coming into the new administration have signaled that they want to make America healthy. They want to address chronic conditions. Well, I think we've got some incredible partners here for them to work with and to move quickly with some bold solutions to try to address what is clearly, a part of the healthcare system that is so critical, but is so under-resourced. A number of a majority of adults and many others that were responded to the survey talked about a whole person approach to care. They described clinicians that had the time to partner with patients and really help to meet their needs, deliver care in a way that recognizes the environment that affects people's health. How, from the research and from your own experience, Tom, how well do you think our current healthcare system is doing that?
We're in a great situation. Your last statement makes me reflect on the bold solution is for the last 10 years, I think we've been building the infrastructure. It's just ready to be unleashed. And all it really requires is the proper funding. So I think you have a lot of accountable care organizations that are implementing social determinants of health screenings, depression and anxiety screenings, and other screenings that are ready to then pivot to partners such as the behavioral therapist or the pharmacist for polypharmacy or a care manager. So I don't think we necessarily need, and this is not an uncommon theme in the United States, new solutions to problems that we already have solved. We just have to be able to implement it and then tweak and improve and optimize areas that we can go. So I can feel for what they're saying. I think we are ready. We are not far off from being ready to go. We just have to be able to finance it in a way that makes sense.
Super. I know we're getting close on time. We want to make sure we have an opportunity for audience questions. And I hope those in the audience are going to ask about affordability because that's such an important finding. Venice lifted some of that up when she did her presentation, but it is really critical. Okay, I've got a couple of questions here, and let me. In Oregon, the spread of value-based payment has been negatively impacted by the lack of alignment across payers. Clinics are often hesitant to enter into contracts without a clear understanding of risk and benefits, and they are overwhelmed by the number of quality metrics they're required to track. Our sense is that it's driving consolidation. Is there any state or national research that's looking at that? And any comments about whether or not value-based care might be driving consolidation?
I think value-based care is absolutely the weapon that's going to help us improve U.S. healthcare. It's just been applied so sporadically where out west in Oregon, there's very robust kind of Medicare Advantage systems on east of the Mississippi. There's very novice systems. So you have changes throughout the United States. And because of the inconsistent slowness of value-based payments, those prospective payments you've talked about, it often has been consolidated around hospital-based groups. So then you have these hospital entities that consolidate, and hospitals think hospitalistically in the sense of we want to drive people into beds because that's exactly how they view the world. So I would say that the questioner is absolutely correct, but alignment of the value-based system, which is easily done at the legislative level, at the state and the federal level. It's just that if you look behind and under the hood, as I think Venice said earlier in one of her statements, is the people that are holding back and keeping it from being aligned are the payers.
Great. This, we've got time for just one or two more questions. You know, if the current administration or those on Capitol Hill could wave their magic wand and improve primary care funding tomorrow, how would we as a country meet the demand for primary care clinicians?
Schools. I think you have a lot of the schooling, I think, between nurse practitioners, which have been shown that from a care team model, they're essentially as effective with key chronic care modeling like diabetes, COPD, CHF. Not in all areas, but in those big areas, we can really trust their partnership, physician assistants as well. But even as states think about increasing medical schools, there need to be residencies attached to them. So they grow at different rates and create these discrepancies. I think from my perspective, your slide that states people entering primary care, if you dig into that, there's your answer. The reason is because there's instability in the primary care environments. The payment systems are unstable. The payment systems are significantly different than specialists. And when they come out with student loans and they want to get their life going and buy that home, etc., they're going to be doing similar work at a significantly lesser reimbursement. They gravitate towards specialty. And again, specialties have very large, powerful lobbying groups. So again, if they could wave a magic wand, it's funnel the money into organizations that have been doing this for a while, trying to get these things rolling, put it in the right hands of the right people and let them be professionals.
Yeah, if I could add to a couple of things. I think about one of the first things you said, Tom, was around nurse practitioners. And we've heard in a lot of our listening work, especially in rural communities, how people really like nurse practitioners. They actually appreciate the time that they're able to spend and find they're able to listen. It reminds me of also of our patient first care, also known as value-based care work, where we heard a lot of that too. And people just really wanting to feel seen and heard and getting to the root cause of their issues. And nurse practitioners are able to do that a little bit more and meet those needs. So I think that is one thing that we can definitely consider. So that's a +1, Tom. And so, yeah, if we have to think about what's working and how we scale up the innovative payment model, just to kind of double down on what you were saying there.
Thanks so much. I do wonder if we had more resources and that made it possible for, yes, NPs and PAs, but also primary care physicians to spend more time with their patients. If folks that have cut back on their hours, have taken other jobs, have retired early, might come back into the workforce, because I don't think they left necessarily because of the pay. I think a lot left out of dissatisfaction with the kind of care they could deliver. It really didn't meet their needs either, because they want to spend time with their patients. They want to feel like the care that they're able to provide is really making a difference. So that might help. Also, perhaps AI is going to help us with reducing some of the administrative burdens. So anyway, we have to do more than fingers crossed. We have to put our shoulder in and work together to change these conditions. Thanks so much for joining us today. We're going to turn it back to Lisa Hunter from US of Care to close us out.
Thank you so much again to all of our panelists, to our partners. Moving forward, I think United States of Care would love to know what kind of research needs to be done in order to better understand what people's experiences are like with the primary care system and what needs to change. You saw from Venice's research, we've barely scratched the surface. It's a bit of an iceberg, and there's so much underneath what she was able to present today. We were so excited to hear from Anne on the Millbank scorecard and other data that she's putting into context for us, and some of the silver lining conversations that we believe are gaining momentum when it comes to federal policy in this space. Certainly plenty of work and discussion to be had here, and we very much welcome each of you to engage with us as we seek to advance this conversation and ensure that we're all making collective progress on primary care in this country. So we invite everybody who tuned in to please reach out to continue the conversation and collaborate with us. We're sorry if we didn't get to all of the Q&A, but would certainly love to be in touch. A special thank you again to our speakers for sharing their insights and perspectives, Commonwealth Fund for supporting this work, Primary Care Collaborative for co-hosting the webinar, and everyone in the audience for attending. You can expect to receive a follow-up email that's going to include a recording of today's webinar, the slide deck, and additional helpful resources very shortly. So with that, thank you very, very much, and have a great rest of your day.